Hi everyone, it's Kira here from Physio Erin. I hope you're having a good day. I have come on today to talk to you a little bit about knee pain and specifically meniscal tears. So this is a model of a knee. What you see in front of you here is this is a little bone on the outside of the knee. So this is a right knee, same thing happens on the left. This is your femur. Well, actually it's the white bit that's your femur. This is the tendon, the end of the quadriceps muscle that inserts onto your kneecap, which you see there, and then goes down onto the shin bone. So little bone on the outside, your fibula, your shin bone, your tibia, and then your femur. Then if we move the kneecap out of the way, inside you'll see this thick section here. And in reality, this is where your meniscus sit. There are two chunks of thicker cartilage, and I could best describe it as like circular ear type materials that sit on the inside of the knee, and their main job is to make this knee a bit more secure in terms of congruency. So the tibia bone is actually quite flat at the top, and the fibula has two big round balls that sit on it. So the meniscus actually allow them to sit a bit better inside the knee, and their main job aside from that is to absorb shock. So the fibrocartilage, when you jump or hop or twist, it takes the shock, the impact, and it isn't supplied with big nerves like the bone is, so we don't feel it when we hop and jump and twist on our knee. However, for some patients, in some instances, we can get tears of these meniscus, and that's what I want to chat to you a little bit about today. So when we have a meniscal tear, and I'm going to bring up a little picture of what these look like in real life. You'll be able to see this okay when I put it back around. So what we can see here, it's not very great, but that's what it looks like in real life. Those are just some out clips from some training I did, but they're crescent shape pieces of cartilage, one on the inside and one on the outside. And when patients come in with meniscal tears, they're very likely to have done an injury to the inside one more than the outside one. And this is for two main reasons. The meniscus on the inside is a slightly different shape. So its ends attach further apart, whereas the one on the outside, its ends attach closer together. So that means the one on the outside has a bit more wiggle room than the one on the inside. And likewise, when we look at these pieces of tissue on the side, these are our ligaments that connect the bones together. On the outside of the knee, that ligament is completely separate from this meniscus. But on the inside, that ligament is completely attached to this meniscus. So that means when you hop, twist, turn, or squat on that knee, the one on the outside has a bit of maneuvering space. So if it comes under a bit of pressure, it can wiggle a bit, whereas the one on the inside does not. So if it becomes under pressure and it is about to be overloaded, you'll get a tear here way quicker than you'll get a tear here. Most of the tears we see on the outside come with more trauma, so it'll be like a twisting injury from sport, and you might find that some of the ligaments in the middle of the knee, your ACL are torn, or the LCL is torn, as well as that outside meniscus. So watch for other injuries if the outside is sore. So how do patients present if they have a tear here? There's two groups of people that present with meniscal tears. There's the younger traumatic group, and I'm not going to put an age on that, but it's usually more sports related type injuries. And then there are, even 30 plus, 35 plus, you'll get the more degenerative, and I hate that word, but it basically means that the tears come with maybe still trauma, but not the trauma the younger ones are describing. So this is the patient that might be 39 or 40, they're suddenly having pain on the inside of the knee. They might have felt it fairly suddenly coming up from a squat, whereas the 18-year-old is telling you about how they landed and twisted when they were playing football. So those are the two kind of groups that we'll see. And with the meniscus then, it's a case of trying to decide, right, do we need to get it scanned first of all to see what we're dealing with, or do we rehab it first? And that will often depend on the backstory. So for most of the degenerative meniscus, I will never scan it first. Based on the assessment, I'm fairly confident I know what's going on, and I'm going to treat it and I'm going to see what happens. For the younger guys or girls, I'll tend to scan it. And that really comes down to whether or not I think there's potential to repair the meniscus. So this meniscus has blood flow but not great blood flow. And generally speaking, if there's a tear on the outer ring of the meniscus, it has good capacity to heal itself. But the closer and deeper that meniscus is to the inside, the less capacity it has to heal. So there's 3 zones the surgeon talk about. The red zone is the rim on the outside. Good blood flow, can heal, generally will get better for you. The red-white zone is the middle third. It has less blood flow. If there's a tear here, it can go either way. And generally they might try to repair it. They'll definitely try to repair it on the outside if they can. They might give it a go in the red-white zone. If it's in the white zone, which is on the inner rim, there is no blood flow there, no capacity to heal, and often they'll end up trimming that meniscus. So in clinic then, what is this patient saying to me? They're saying they're having pain that's coming and going on the inside of the knee. They're saying that the knee is swelling up on them. They're saying that they can't bend the knee the full way down. They're getting pain when they're coming up and down the stairs into a deep squat. They can't kneel on the floor with the kids. Or if they're a bit more active, they might be saying that they can do all the things day to day, but the second they go to run on the knee, they're getting pain on the inside and they can't bend it properly afterwards. Those are the kind of things, if they sound familiar, then this could be going on. When they come into clinic then, we might see a bit of fluid in the knee. It might not be that swollen because the swelling tends to be intermittent and recurring. So when it aggravates, it'll swell up, but when you ease off, then the swelling will go. But they'll definitely have joint line tenderness, pain on the inside of the knee. They'll have pain when we get them to go into a squat position and we twist it. And sometimes they'll have pain when we go to extend it. So our tests will start to tell us, yeah, there's definitely something going on the inside of that knee. And from there, we decide what the best course of action is. And we know from the research on meniscal tears, especially the degenerative meniscal tears, most of these patients can get significantly better with physiotherapy alone, and we do not need to be operating on them. And in fact, having surgery on them is definitely not the first resort. And if your surgeon, if you have a meniscal tear, if you're say 35 plus, you've had a known meniscal tear and you haven't done physio and your surgeon's operating on you, they are not doing evidence-based practice, because the literature on this shows us that at 6, 1, 2 year follow-up, those that do physio, most of them can become symptom-free with physio alone and don't actually need the surgery. So for every 10 meniscal tears that we might see, 8 of them will do really well and 2 of them might then go on to have the surgery. But failing physio first is a good idea, because if they go in there and they take out some of that meniscus, then you are more likely to have osteoarthritis in that knee down the line. If they repair it, you're less likely. So now they do these partial meniscal or meniscectomies, which means they're trying to preserve as much of the meniscus as they possibly can. And that is because we now know if they take the bigger chunk they take out, the more likely we are to have arthritis in that knee down the line. So physio first. And also, the stronger the leg is, the better you're going to be, even if you go on to have surgery. So what do? Well, we focus on getting range of movement back first. So we might mobilize this knee in the clinic. If you're stiff, we definitely will. We'll work then on strengthening around that knee. The more force we can reduce going through this meniscus, the better it is. And it won't be just the knee joint. A good physio prescription of exercise will start higher up the chain. You'll be working on the strength around your hip and the muscles around your knee. So I'm talking glutes, quads, hamstrings, calf muscle strength, everything that goes around this knee to try and support it. We'll often start that strengthening work where it's pain-free, not irritating the knee joint at all, and sometimes we'll even start non-weight bearing, so you'll be on the bed doing resistance type work. The second phase then will be trying to get you back to full function of the knee, so that's full range of movement, and then weight bearing strength work, and that's where things like your step ups and squats will come into play. And then further down the line, we'll look at what your goals are. What is it that you need to be able to do? And then make sure that you can do it. So for some patients, this will be, I want to be able to go for my walks, I want to be able to do my golfing, and I want to be able to play with the grandkids. If we can do all those things, tick, 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 we are not sending you on to have this scanned or to talk to the surgeon. For other patients, it might be, I want to run on the knee. So a more recent case of mine, we could get this knee pain-free, no problem, day to day, could do everything they could do. They were in the gym, squatting, deadlifting, playing with their kids, fine, but could not get the patient running. Every time they went running, joint line tenderness, pain at the end range of knee flexion, and intermittent swelling. And so then it was a conversation. How much do you want to run? Do you want to run now more than you're willing to worry about the risk of having arthritis down the line? Yes, I do. Scan the knee, lo and behold, radial meniscal tear, which is a tear on the inside with no healing potential. So I got this patient pain-free day to day. The tear was still there, but it was a radial tear. It's not going to heal. So in order to get him running and allowed to compress on it pain-free, he went in and had that scoped. So, bit of guidelines there on knee pain. If you're having pain on the inside of your knee, if those symptoms sound familiar, physio can help. And we definitely can. We're here to help. Have a good day.